Introduce Dr. Vincent Speckhart. Dr. Speckhart graduated from New York Medical College in 1958. He was on the faculty of the Eastern Virginia Medical School for 17 years. He was the founding president of the Virginia Oncology Group in 1980, and he has been practicing alternative medical care, complementary care in Norfolk, Virginia since 1986. Dr. Speckhart.
If you don't mind, I'd like to just step down and talk from the view box. Thank you very much for inviting me here to this conference today. One thing about giving a conference is that it focuses you a little bit on problems at hand. And ever since I've met Ed Arana, I've been aware of the fact of dentistry being a big problem. But I approached it with a great deal of caution. But have become more convinced ever since that it's one of the central issues. And this morning, what I'd like to talk about is the cofactors and the multiple factors that are involved in chronic illness, among which is cancer. It's very important for us to realize that we pass through life and pick up a lot of stuff environmentally, and this is transferred into our body and becomes part of us. Not only us, but the adventure of our parents through life has also brought a lot of information into our bodies. I was a fairly standard oncologist until it became apparent to me that nothing was happening with chemotherapy, and that actually it was creating more problems in my life than I felt the academia had been promoting. You never hear in our circles such words as "it's not any good." You always hear this needs further study. So we have always referred our patients out to institutes for further study, and we seem to get nowhere. The fact is that chemotherapy is useful if used properly, in some cases for a very limited reason, but it is not useful in the manner in which it's given right now, and is quite toxic, and in my judgment violated every principle of therapeutics that I've ever learned. Well, since I've got religion, I've come to a new understanding of the way things are, but it's a bear to get out of the system that you've been oriented into. But I've come to realize that basically there's nothing wrong with you that what's right with you can't cure. And I think that's an essential feature of what this talk is all about. That it's the dictum of the holistic physician, that your body basically does the healing, and the drugs don't do very much. One of the things that I was involved in was clinical research in clinical oncology, and I found that we were just reinventing the wheel all the time. And so I brought this slide along to focus me in, and this little sign that says, "Thank you for not doing research that has already been done." And I think that's what my talk is about today. I don't think you will have ever heard anything quite like the presentation today, because it's from a totally different perspective. One of the concerns I've always had, even in this field, is that we focus in on one thing. We say, well, this is the cure for cancer, or that's the cure for cancer. And we have all these things, and you run around, you find, well, yes, there's a certain degree of truth in all of it. And I think what we really have to do is to look at the broader picture. What are the causes of cancer? Not just one cause. There are multiple areas in our environment, and many processes that we go through that are etiologic in cause of cancer. So there are many cofactors, is what I'm saying. Now, I think I'm going to have a little trouble with this. probably, in terms of being too close or too far or too what. I don't know. I think maybe if I push it up a little bit, I might be able to.
Just keep the screen a little closer.
Yeah. Here, let me help you with that. Okay.
Maybe you want to take it back.
Yeah, maybe take it back a little further. You can only go back so far, otherwise you're going to be off the stage.
You can go back to 6 inches.
You can go back another 6 inches on this.
The problem is it doesn't fit on the screen, or?
Yeah, let me move this back. Yeah, move the table back.
Sit it up on top of this?
Well, let's try that. Okay, can you lift that? Well, we'll work it out. It just requires a little manipulation, that's all. What I really want to do is just to show you today the multiple biofeedback signals that I get using the electroacupuncture ball. Now, I'm not going into the EAV other than to say that you test on various points and you get some signals that come back. You stimulate the host, and one of two things happen. Either you get a balance and there's no change in the indicator drop, and so it goes burp, or it goes down. Burp, okay? So that's very simple. I can understand that, everybody can understand that, and it really is a simple device, a linear evaluation. So there are multiple feedback signals in chronic diseases. And the chronic diseases that I think about are cancer, neuropsychiatric, musculoskeletal, cardiovascular, and urogenital. And that's basically what my practice is. Now, this talk is basically going to be about the marketplace, you know, what I do all day long. And what I've done is simply to use the Computron. I use Doug's device. It has a very big library on it, and it's quite comprehensive. And it simply happens to be the device that I'm used to. It doesn't mean that others don't do the same thing. And so basically this is a report on that device. And what it does is capture the signals and put it into my C drive, and I can now convert this into a database. And I do that on a periodic basis, just take all the information off and put it on an Excel database. And now I'm beginning to collect data on all of the information that's fed into the device. We now have about 1,500 cases that we can analyze. So as time goes on, I'm getting more experience, and we're getting a more valid database. As I get experience and I see directions the way we have to go, I can now present some information that might be relative to the nature of different chronic diseases. Ed Arana asked me to come here and talk to you guys, and what I really want to know, what you really want to know, is where does biological dentistry have a place in patient care? The question was just asked before: is dentistry important in terms of tumor? I hope to show where it fits in today. And where does it fit in? It fits right here. In the 446 cases that we've evaluated, patients with heavy metal and dental nosotoxicity comprise 40% of all the patients that walk into the office. Now, that's not 100%. Some of you, I'm sure, feel that all disease is related to dental, or a large part of it is related to dental problems. I want you to understand that this is my experience over a limited period of time, and as I get to understand the disease, I'm sure that we're going to get more cases and a larger percentage. But this is my initial introduction in the first 446 cases that we investigated. That's only from the mid part of this year. The nice part about computerization is that everything you do is written down. I mean, it is recorded. So, you know, you can gather a lot of data pretty fast. You don't have to sit down and separately tabulate it. I don't have to hire anybody to do it. the data is right there. So 40% of all those that come into my office have a dental or a dental heavy metal problem. Now, a couple things to be observed. Is that we started this in June, and you can see that I was recording about 30% then. Then it would drop down into the 25, 30 range. And in September, it began to rise. And I think probably as time goes on, I'll probably be in the 45 to 50% range of dental heavy metal problems. So you do have a very significant role to play in healthcare.
Did the 446 patients come since June of this year, or over a much longer period?
Over a longer period of time, yeah. Mm-hmm.
All cancer patients?
No, not all cancer patients, everything. Yeah. Mm-hmm. But dental problems are a major health problem. It's not 90%, it's not 2%. It's about 40 to 50% in case, so that's a significant amount when you think about it. And one of the important things is that if a patient has a dental focus, 68% will have dental nosodes or heavy metal problems outside of the mouth, outside of the area. So it expresses itself in many different areas.
Do you have a listing of the criteria you're using to judge the dental impact?
Yeah, well, it's the standard EAV criterion. If you get an indicator drop over an acupuncture point, I hope to point this out during the talk, and you can correct that indicator drop by means of a dental nosode, either the metal or the whatever it is, then that would be a signal of identity. So these are EAV signals. One could, this is a new science. It's a new language that we're using as to the implication of this. Now, it gives bioenergetic feedback information. It has to be understood as that. Is that a diagnosis? No, it's not a diagnosis. It's simply an electromagnetic signal balance. Is that useful information? Yes. How can you use that? And I hope to get into that as I get on. The most common heavy metal dental nosodes are non-gamma 2 amalgam, Merck Vivus, osteosclerosis of the jaw nosode, silver, metallica, vanadium, lead, aurum, mercaptan, pulpitis nosode, and tin on the bottom. I don't have the numbers. I wanted to make this into a teaching session and not a publication. When we get to publication, then you put down the numbers and things like that. I wanted to give you an overview. One of the criticisms my son had of our previous presentation, that it was just too much information to get bedazzled by it. So I wanted to keep it a little simple and just to emphasize that non-gamma 2 is an important problem. I was just reading in the little brochure from Germany on heavy metal toxicity that non-gamma 2 is the big agent in Germany that seems to have the major toxicity, and I do see that here. Yes.
What about palladium?
Well, it's all in there, but it's not the major one. Okay, these are the ones that are most common, and that's a broad statement. But yes, I think anytime you put anything in the body, it can be reactive.
You don't find it as a major one because with regard to specific immunopathological reaction, you do find frequently products with palladium and gold.
And gold, yeah.
So they go together.
Well, I wasn't impressed as much with gold as I am with mercury. Mercury is obviously the big one now. Now, the slide that I showed before showed that I didn't see very many before, but I'm seeing more now. Now, that may be a function of two things. Number one, that I wasn't looking for it. I wasn't knowledgeable enough to look for it. although I look back at my old charts and I was recognizing it and treating it with homeopathic nosodes, but, and the patients would get better transiently, okay? And then I'd be bouncing up against this wall, the patients would come back in again. And then I wouldn't see the mercury at that time because I had gotten it out of the tissue, but it still had its bioenergetic effect. Now that I've cleaned out all the other nosodes, the infections, the fungi, the pesticides, the herbicides, the only thing left now is mercury and gold and those other things. So it's becoming more significant to me now, and that might be a function of effective homeopathic prescriptions and herbal prescriptions and drainages and things like that. But now, the only thing left is mercury, so you've got to take it out, or whatever the dental problem is. So what I'm saying is that I think it's the root cause of a lot of stuff, and you have to deal with it.
Are they in any order? Are those in any order that you found them?
No.
That's random?
I have my most frequent series after a while that I did earlier that I reported out in Salt Lake City. But this is more for just general discussion. Notice that not only do you have heavy metals, but these other foci like osteosclerosis of the jaw, as a result of extractions. And fibrous connective tissue that occurs at the site of injury. That's all a problem. Pulpitis nosode on the bottom also is there. Now there are a lot of other things, and this is not the definitive guide. I think as time goes on and we get larger and larger numbers, your numbers get to sort themselves out in the proper order and in the proper frequency. And that's purely a matter of of numbers. And that's what I really wanted to do with my study, or as I look at my practice, is simply to ask, well, what are the problems and how frequent are they? Because what you have to do is develop a science, and if you're going to do a screening process, if we can establish this as a problem, and you're going to establish clinics, then you have to have what's the most frequent, so you can design your equipment to get a technician to do a screen and to focus in on the major areas, and then as you go up in your skill level to define what are the more urgent problems and to put perspective on it and to design therapy. But the initial will be a screen. And I can tell you the screening is something that we've missed a great deal, at least in this country. Okay? So this simply says that heavy metals and dental nosodes are key. Things like mercaptan, as I understand it, you can instruct me on this, is simply a breakdown product of tooth material, and that is a problem as well. Now, where do the signals go? Of a total of 138 points affected. We see that it's reflected in the LY2 point, which is the tooth drainage point, lymph drainage for the jaw and teeth. I find it frequently in the second molar, lower molar, and on the first molar. I find it projected to the urethra, penis, and prostate, and so that's the bladder 65. That includes in the female the cervix, the uterus, the vagina. So it also is a head focus, a chakra point up here. So we see it there. So you can pick it up not only by the lymph drainage area of the teeth, but you can also see a head focus up here. The signal is seen in the cerebrum. Well, that has important significance as far as mental capacity. Doug Lieber has described a point called secondary vessel 90. He has a whole group of these secondary vessels. And secondary vessel 90 is gums. And that's a poor word in front of you guys, I know, but that's basically a simple way of expressing it. And the second lower bicuspid, and it's also found in bone, which doesn't surprise you when you consider that it's a metal and the nature of the bony structure. Now these are simply observations that I made. I have nothing really very profound about anything that I've done here today. Is just to tell you, well, this is what I'm seeing. And I do it day after day. I spend about an hour, hour and a half on each patient. And I am very methodical. I have the same routine, every patient, because I just want to acquire data. It's very important for somebody to do that. I see a lot of dissipation, and my thought was to really sit down and say, okay, what is the real problem, or how can I define it to help others in the field to develop equipment or to develop a science? Yes, ma'am.
Can I have just one question? What about control material? People, healthy people who have amalgams and gold, do you find any noise? Or do you see any problem?
Well, that's the 60%. In other words,
I thought
40.
they were cancer patients. Well,
Pardon?
I thought they were cancer patients.
Oh, no. These are just general patients that walk into the office. I don't just see. I'm not a cancer specialist anymore. I
I'm
erased
sorry,
that. Okay.
I'm talking about healthy people,
Uh-huh.
people like you and me. Is it what?
Yeah, who's healthy?
Well,
Very few.
by definition.
Well, I don't see healthy people. They don't come to the office.
But
Healthy people don't come to the office.
Yours is a general practice, is that correct?
That's what I've degenerated into, or ascended into. I think that's about, yeah, I think so. Yeah, I've graduated into general practice. I really, that's where my heart is anyway.
Accelerated.
That's right. It's a lot of fun, I'll tell you. You really see healing for the first time in my 30 years of practice. I'm beginning to see it. Okay, now, what do I do? You know, case management. How do I do what I do? Okay. Well, first of all, we have a hand-to-hand measurement, and that simply tells me about the general level of energy, whether there's inflammation or degradation. And it's kind of interesting, you know, when I first started out on this, cancer patients would come in bouncing off the bottom. You'd see a hand-to-hand of about 30%. Normally, it's 0 to 100 would be the scale, and you're down to a degenerative level of 30%. I just had a patient the other day who had far advanced cancer. The tumor is gradually going away. And she is toxic from tumor breakdown. You must remember, when a tumor breakdown, it's like putting a piece of meat out in the sun in some water, and it just putrefies. And that has to be degraded by the body. Okay? So you got a big pus pocket in there, or a potential pus pocket that's got to be dealt with, and physiologically. So it has to go out through the macrophage system, or it has to be eliminated through bile, or excreted through the gut or whatever. But it's a matter of detoxification. And you can get very effective cancer management, but have the patient die or get severely ill because you're not detoxifying them in a proper fashion. That's an area that really has got to be dealt with. So I have taken the ultimate leap. I mean, I have gone over the edge, and I give coffee enemas. And they work. I mean, patients really do, and they need it. You know, so coffee enemas are quite useful. So we don't talk about that except now, and probably, but I don't really care what I say anymore, because you're not going to convince your opponents, so don't worry about it. So anyway, we see the general level of energy, and I find that the patients that I treat now, even though they have advanced cancer and they may be losing weight because of toxicity, have a hand-to-hand of 80. 80. I mean, you see that in healthy people. I had a patient the other day who was losing weight, and I don't know how to, you know, I'm in the process of trying to figure out what can I do to get this lady to start eating. So I'm into enzymes and everything like that, but the point of the matter is that she was 85. She had almost an inflammatory reaction. This is not a degenerative signal as by the EAV criterion. Okay? Then what I do is I measure all of the control measurement points on the fingers and toes. Now, I do that routinely. So if I have a specialty now, I tell my patients I'm a finger and toe doc. Okay? So I locate the meridia of concern. In other words, what I really do is to try to screen the patient. Is it a gastrointestinal problem? Is it a pulmonary problem? Is it an organ degeneration problem? Is it heart? Is it whatever? You know, try to get an idea of where I have to concentrate in my exam, and that's all recorded. And you get a nice graphic to see where it is as by the indicator drops. Now, the first thing I do is to test the LY1-2, which seems to be a general point right here. And It's a CMP for the immune system, especially of the head and neck area. And in this point, it goes down every time. In other words, you get an indicator drop every time at the LY1-2 point. Now that's fairly significant. The energetics of that point must be something that it demonstrates a fact. And what I see happening at this point always is a polycrest, or if the polycrest is involving many different areas, you can actually say, well, this patient has a constitutional. So depending upon the degree of penetrance of your polycrest at this point will define the constitutional type. And I think this is important, as I'll show you after a while. Patient will come in a real motor mouth, very almost flight of ideas, can't get the words out, complete sentences. They have left-sided events. They can't stand anything tight around their neck or around their middle. They're constipated. They have skin problems, and they'll come in really agitated. I mean, you can pick them out just like that. That's a lachesis as far as I'm concerned. And that's important to know that, because that's an essential resonance that goes through the body. So I think it's important to correct that essential resonance. And what I do is to see whether the patient is a lachesis or a sulfur or a calcarea, or I had one rhythmic dancer the other day that looked like a prissy old maid, but she was into ballroom dancing, and she was schizophrenic, and she was a stramonium at that point. So you can see an awful lot about the patients and learn a little bit about their history and point your direction. Now, I tell you, before I do all of this, I sit down and interview the patient. I have a long sheet, thanks to Charlie Farr, and his very comprehensive history and physical sheet. I use that, and it's a very good form. And I use that all the time to get an idea of what the patients have. And the boards love that kind of thing. They're really impressed. As the board told me in my review, "My, this is interesting. Where'd you learn all that stuff?" Well, it's nights and weekends, and because I go out with squirrels like you guys. Okay. But they're very impressed. And the oncologist who reviewed my case said, "My, we don't know everything, do we?" I felt like saying, try the word anything. So we're really on a learning curve, and it requires a new language, because where we are, nothing works. Okay. Now, after the LY1-2 point, I see almost invariably you can correct that with either one of the polycrests that Doug has on his computer or one of the constitutionals. I see that all the time. Then I go to OR1-1, and I've just observed this, that I will find the lymphatic burdenings of the anaerobic cell metabolism, and what I see there is an inclusion in the miasmatic list that Doug has. I don't have that on a chart, I missed that. But that's basically where I look into miasms, okay? Incidentally, the LY1-2, it gives you some insights into constitutionals, and I'll discuss this later on. Constitutionals aren't always present. There are some constitutionals that are very fixed. There are other constitutionals, I think, that are transient. And you can see them, and if you know your constitutionals, you can identify these patients and their constitutional at the time of the interview. You can repertorize them in your own mind and say, well, I have a lachesis or a sulfur or a calcarea or a Merck Vivus or something like that. This is fairly standard homeopathic repertosation. In any event, the OR1-1 emphasizes one of the miasms being serinum, menarinum or gonorrhea, syphilinum or leucinum, tuberculinum, and Doug has a whole list of other subsets of tuberculosis, the Rosenbach and residuum, and a whole group of others. And also things like lymphogranuloma and scarinum. Scarinum is a very important miasm, especially in terms of scar tissue formation and chronic infection. So then we go, and then I, being a physician, I say, well, how can I approach the environment? What do you breathe in? And so I just started to test the LY3 or paranasal sinus point, and I found that this really does correlate with some things that you inhale. And the biggest one that I find is chlordane. And chlordane is found, if you have an indicator drop early on in your evaluation of this patient, it's almost always chlordane. And the reason for that is, you couldn't get an FHA loan on your house unless it was termite proof, in this country anyway. I've had people from Great Britain that don't have that problem because they have houses built on concrete or on rock, so they don't need termite control. But here, we have a lot of problems with that. So I find that chlordane is a big deal, and it's one of the major pesticides that I see in my daily practice. Then we go to things, and associated with this, there is not infrequently a fungus form, and it's not infrequently in severe cases of sinusitis, aspergilla, one of the variants of that. In any event, we go now to what things are ingested. So we breathe and we eat, okay? And the things that I see ingested are DDT. Now, both DDT and chlordane have been outlawed in this country since the mid-70s. But they have a long biological half-life, and they're still in soil. And it's still coming in from Central and South America, and we do still have DDT as a problem. And I hope that after a while get to discuss that, because DDT is related to Candida species in the gut, and that's related, so we have the DDT, candidiasis, and gliadin intolerance, or wheat intolerance. Those three are connected. The importance of that is that if you correct the DDT, you correct the leaky gut caused by the candidiasis, and consequently you cut down on the malabsorption of gliadin, which is very toxic. So that little triad seems to be holding up. Okay. Now, I want to get into some case studies. The bottom line of all of this, if you expect change to take place, it's not going to be due to academia. It's going to be due to people that are pressed into consider other things. I just had a little discussion with the people I'm on a Senate committee in the Commonwealth of Virginia, reviewing the laws of the Commonwealth regarding pain management. And one of the comments of a pain manager of their main pain clinic is that we really don't care about the therapy. We're concerned about the cost, and if classical pain management doesn't work, then we will consider chiropractic, acupuncture, homeopathy, and massage therapy, and all those other alternatives. The Board of Medicine was there, and I could hear dentures dropping all over the place as they opened their mouth and had that from two separate people. So I think there is a consensus that even though we don't know about what these things do, that bottom line, if we have effective therapies, they will buy into it. Okay, so the correction may come through the HMOs. Well, this is a case study. This is a 35-year-old female with chronic granulocytic leukemia. It was biopsy proven. She had a high white count, a sore throat, and a big spleen. And she had the Philadelphia chromosome identified and all of that. So that was all done in a Class A university. And this lady said, she's a nurse, and she said, I didn't want to have chemotherapy because she reviewed all the stats and she didn't find it to be very useful. Now, that was her opinion. She came to my opinion in my place, and I have a big disclaimer that I will only take you if you are under the care of a qualified oncologist, or if you have heart disease, under the care of a cardiologist or some other professional that practices orthodox medicine. But I am here to engage you in my clinical investigation program, which is basically a data gathering organization right now, consisting of myself. Okay. All right, well, the way I wanted to do this, I don't know if I'm sorry, I'm going the wrong way. Okay. Well, this is a very complicated slide, and I apologize for it, but I really wanted to put it this way to start out with, because it shows the degree with which you can use this device. And what I wanted to show you first is the points that came up on this individual. I spent about 2 hours and 15 minutes on her. I mean, that's rapid fire, 2 hours and 15 minutes. going over everything, retracing everything, and I consider it to be a fairly comprehensive review of this lady. The points that I tested were the allergy point. I'm sorry. Okay. Oh, I see. Okay. All right.
May not show up in the white background.
Pardon?
Yeah,
No. No, the business end is right here. Oh, there it is. Yeah. Okay. We have the allergy point, the bladder, 66, gallbladder 39, which is the bone marrow, and that's a point that Doug has pointed out. I just wanted to show that all of the bone marrow was the key point right here. There are 22 points that had indicator drops when we check the bone marrow, and that's where chronic granulocytic leukemia grows. It starts in the bone marrow. That's where the bone-forming elements are. Okay, so that's very important. The lymphatic system, 1-2, that just showed her Lachesis state. The lymph drainage from the teeth, very important, as we'll get to it. We'll get to the dental portion, if I can see that. Right here, right? See how many points you have from dentistry? See how far they penetrate? So you had the paranasal sinuses. We looked into the organ degeneration, cellular metabolism. This is the lymph burdening of the anaerobic cells. That's where the miasm shows up. Lewisinum, very, very important. We'll get to that. Small intestine, skin, spleen. She had a large spleen. Look at how sick her spleen was in terms of energy disturbances. And the neutrophils, secondary vessel 64. No, it's 1, 2, 3, 4, 5, 6, 7 points down there. Okay? Now, so we know the points. Now, what are the problems? This is less than satisfactory in terms of okay. Well, the thing that we want to see first is that we can identify.
You can see the whole thing if you want to tilt that right at the very top. Tilt
This thing here?
yeah, tilt that out.
Oh, okay, I'll do that right. The things that are most important are that you can identify are that you do have some nutrient problems. Here's bromelain, PABA, papain. So they do have some effect, and it's interesting to see where they are effective in the bone marrow, in the cellular metabolism, and in the spleen. Okay? The same thing of papain. So it gives us some insights, Dr. Scheidel, as to where these things are found. An interesting factor is that wheat or white flour is quite toxic in a lot of conditions. One wouldn't think that eating a piece of white bread is going to affect your leukemia, but it does, at least energetically by this technology. Aldicarb, a chemical that's used in growing potatoes, it's a pesticide, was important in the bone marrow and in the spleen. Butane affected the bone marrow. Candida tropicalis, as a result of DDT, affects the bone marrow and the small intestines, but you still have the weak fish of the whole area is the bone marrow. Chloridane affects it, and DDT does not, surprisingly, but it does affect the neutrophils down here. In other words, it has a more peripheral effect than does do the other agents on the more central area of the bone marrow. Natural gas, one wouldn't think that would be a problem, yet in this case it affected both the bone marrow and the neutrophils. And the point is that she lived in a natural gas environment. They used it at home. She's from North Carolina, she lives out in the country, and they use propane gas or natural gas. Non-gamma 2, okay, it affects the allergic process, the bone, marrow, the lymphatic drainage of the tooth area, the cellular metabolism, skin, because the DDT is generally eliminated through the skin. I see that all the time. It goes from the control measurement point of the small intestine to the lymph drainage area of the small intestine, and then I'll pick it up almost anywhere after that, usually the skin. And it goes out through the skin, and that's the last place that I see it. Here again is natural gas, same thing, non-gamma tube, phenothiazine, tobacco and wood smoke, xylene. It's a petrochemical distillate. You probably inhale a little bit of xylene every time you fill your gas tank. It's a very important solvent in organic chemistry, so it's kind of ubiquitous. Aspergillus niger, as a result of the chlordane involving the sinuses, are also factors involved somewhere in this process. And the last part is the leucinum, or the syphilinum. There are 5 points there. And I've never seen a case of cancer that did not have a leucinum or a syphilinum someplace along the line. I had another patient with chronic granulocytic leukemia that is now 4 years down the road, and he still never really got better. And just this last interview, he, in our conversation, he said, well, you know, I did a rectal on him and to check his prostate, and asked him just offhand, did you ever have a vasectomy? And he had a vasectomy 35 years ago, and it was located in the vas deferens, and there it sat for all these years, and probably was the focus that I missed. And he did have a lower abdominal focus. So we have to look for syphilinum all the time, I think. In lymphomas, as I'll show after a while, tuberculinum is the major issue. There are other incidentals. Some of these are major and some of these are minor. The paratidium, or mumps virus, Staph aureus, and trichoderma were seen. Now, lachesis in this individual was also the case. She was another motor mouth. She came in and could have, if I would have allowed her, told her whole story in about 3 minutes. I mean, she had it all memorized and it was all going out. She was lachesis as far as I was concerned. Now that apparently is an important area, an important constitutional. I see that on a lot of patients when they come to us initially. Well, so the point right here is that, and I want to make this try to get you to some understanding. There are multiple factors involved. I didn't add up all the different points, but maybe we could develop a score on that as to what are the, how many points do you have before you get a particular tumor. But this is an interesting slide because it gives you a comprehensive view, and it hones in on exactly where the problems are. So it gives us another appreciation of how to approach the patient with chronic granulocytic leukemia. You can't just say, well, you're going to give this, or you're going to give that, or you're going to give a complex 14-drug combination and try to kill those suckers. That's not the approach. The approach is to identify these abnormal signals and correct them so that the body now is healthier. And as I will show after a while, when you do that, you can give some chemotherapy that is very effective, and you only have to give it for a short period of time, and it is non-toxic in that form. You can give it at the correct dosage and the correct timing. So, but that's a whole science that has to be worked out with more than one guy than me. I mean, I'm just one. I hope to point out the fact that the genesis of tumor is multifactorial. It is not that simple. And when you get into products to correct these things, you want to have all of the inhibitors to effective enzyme therapy eliminated, or effective herbal remedies to be eliminated. If you do have substances in these herbal products that are anti-cancer, that affect a particular part of the cell, you want to be sure that the membrane transports are okay, that the body is basically healthy, that lymphatic drainage is corrected, that all the heavy metals, all of the toxic influences from the outside, the pesticides, herbicides, and all of that are corrected. Then you can approach your patient with a variety of more standard approaches. The chronology of treating is just backwards. Patients will come to you after they've been unloaded, have been treated with chemotherapy, and they've been basically intoxicated to the point where they're mostly beyond recovery. The ideal is to get into this type of detoxification program. This is by far not everything that we do. As I tried to mention before, Rintocoffean is we are doing enzyme therapy. So there's a lot going on. There's a lot of herbal medicine that we give out too. But that's not the purpose of this talk. What I want to show is that this is a very complex etiology. Now this next case, and this is case management, okay? Diagnosis was made in June of 1993. He had a big lymphoma in his neck. And it looked to me, obviously, that there was some tooth involvement. And it was right at the angle of the jaw, and he actually had a squamous cancer. Somebody said he had a squamous cancer underneath his lymphoma. Well, this is biopsy proven. He came down to one of the clinics in Mexico and remained stable. Eventually came up to see me. And I saw that he had this large mass in the right jaw and in the submental area. And he too was a lachesis, and he had bad skin. He had a coloboma of his eye. He had all of the classical signs of a lachesis constitutional. His first treatment was in April 27, 1994. By September of 1994, he had a complete response, and it cost him $1,904.46 through my office. Now, the reason I put that particular information up, if you're going to impact on any of the regulatory agencies, you have to show case management, you have to show benefit, effectiveness, that is, and cost effectiveness, and you have to show lack of toxicity. They're the things that we're going to be judged on. Okay, now how did I approach this man? Well, I went through the same routines that I did. You know, went through all the 40 points, and I do that on a routine basis simply because this is all computerized, and the computer can work through things if I'm consistent in what I do. It's not that it's the only way to do it, but if you want to generate numbers, the program is written in such a way that it looks at this and this and this and that. Well, anyway, this man, he had this huge tumor, and he was lachesis on 4/27. He was lachesis mutus, and when I tested him at that point, he had an indicator balance with all the X's. I couldn't believe it. All the way up to 4,000 X. So I think there are 23 of them, aren't there? Something like that in it. Yeah. So he was really lachesis. I mean, there's no question about that. Even clinically, I didn't have to do the EAB to determine that. But what I did do is to make a homeopathic remedy that was all X. The other thing was I found that in the palatine tonsil area that he had other things. Not only could I pick up a malignant lymphoma at 3X, which showed that it was fairly large, the size of the tumor, from what I can gather roughly, is inversely related to the X. So if you have a 3X, it's a certain size tumor. And so other things at the palatine tonsils were Corynebacterium, anaerobic organisms, Salmonella, diazinon at 25%. I don't think you have that in here, but some Christmas tree farmer brought diazinon 25. I find that to be quite useful. I see that a lot. So apparently, all diazonons are not created equal. I think at different concentrations you have a different signal, and we may want to include that. Okay. And DDT 1X was found. Was found in LY1. Usually, you don't see DDT there. You usually see it in the GI tract and in the skin. Chloridane you see in the paranasal sinuses and in the genitourinary area. Okay. And then we went down to the lymph drainage area of the teeth, and we found we had non-gamma 2, Endemoeba gingivalis, so he had sick gums, tetanus, Clostridium tetanus, 2X, so it probably meant that that the organism was there. There must have been some necrotic material in his gums. Salmonella, once again the Corynebacterium, which I picked up there, was also present in the lymph drainage area. Candida tropicalis and lachesis had its influence. Okay. Now, I'll have to, in order to show you what happened, he came back a month later, and he now transformed from lachesis mutus. He was really feeling better. He was kind of laid back. He felt a lot more confident, and he was eating good. And I found that he had a calcarea carbonica signal at LY1-2. I don't really know what that means, other than I do know that he did not stay a lachesis and he didn't behave like a lachesis when he came back the second time. Calcarea continued in June and in July. Now I want you to see what happens to DDT when you treat using, I used the imprint method, and I made DDT 4x here, and by June it had gone up to 100x, and that's what you usually see. You see it go from 4 to 12 to 200 to 1,000, and then you don't see it anymore, and then it'll translocate from the control measurement point to either the lymphatic drainage of the colon or to the mesentery of the small bowel or to the skin. But you do see that signal. Usually this signal that you see here will be seen in other areas as well, although that doesn't hold true all the time. The malignant lymphoma signal came from a slide that I have. Simple, a well-differentiated lymphocytic lymphoma. But it changed a little bit. It went from 3x to 6x, suggesting once again that you had an inverse relationship between the size of the tumor and the x. And then in June, for some reason or other, he got a signal for a large B-cell lymphoma. So it meant that we know that tumors are all mosaics, and part of that tumor had changed over the period of time, and the large B cells were predominant at this point, but the X had still gone up. That's an interesting observation. I don't know how precise these slides are. By June, it had gone up to 48X. And it was at this time that I began to see a non-gamma 2. Now, I also treated this man with Cytoxan. His tumor was stable, and time was wasting, and he was under pressure to have something done about this. And the surgeons were saying, you better take that out, or you're going to die. And so I gave him some Cytoxan, and my observation in that circumstance was that one pill 3 times a day for 2 weeks caused no bone marrow suppression, no hair loss, no discernible immune dysfunction. He rested for 2 weeks, and I gave him another course of Cytoxan. The tumor went from a huge mass down to nothing. So by June, he basically was free of disease. So the other things that I see, LY2 now, non-gamma 2 went from 3x to 6x to 15x to 24x. So you see that you can affect the change, but I'm of the opinion now that even though you can affect the change, that you really have got to take out the mercury amalgams. And there's a little technique about that. I won't discuss that now, but there is a technique that you can use in order to determine whether homeopathics are going to be useful or whether you have to actually have a dental procedure. It's my opinion that all of these have to come out. All of the mercury has to come out. Although you can, with homeopathy, take away the signal that might be in the soft tissue surrounding the tooth, but eventually it's going to show up again. As time went on, in August, he now went from a calcarea, and he got over that recovery phase, and I think calcarea probably represents a recovery phase, and now he's back hard charging. This guy owns a big corporation, and he's out there. He can see life ahead of him again, and he's spitting fire right now. So he's very much in charge of everything. So he's remained sulfur now, and I expect that to be the case. His lymphoma by August 8th was 4,000x. Then after that, I couldn't identify it. And the nice part about having it so superficial here is you can measure it with a pair of calipers. And I didn't want to put it on this slide, but you can see the actual decrease in size of this. And but I want to emphasize this, that the issue here was not lymphoma. The issue is a dental focus and all the complications that arise out of that. So yes, you do have an important problem, and he has had the mercury taken out, and we are giving him DMPS and chlorella and all of that, and I think that's very important. So you have a more central point here than I'm following up. I'm getting rid of the lump and the bump, but the problem is not lump and bump. The problem is the causative agents that go into it beforehand. Okay. Now, this next case is another case uh, of a cancer. It's called porocarcinoma. It's an eccrine tumor of a sweat gland. The eccrine means excretion, and it's basically a sweat gland tumor. And he was a 43-year-old male, Vietnam vet, exposed to Agent Orange, 1968 to 69. He had a primary tumor of the scalp removed 8 or 9 years ago, and it came up as a group of lymph nodes right back here. And it's a big 10-centimeter mass. The primary tumor was excised without local recurrence, but he has this metastatic lesion that appeared 2.5 years ago. His response thus far is stable disease. It's less fixed. And he's a case that is still trying to decide whether he wants to have his mercury taken out. And he's in the process of doing it right now. I told him I really didn't care to see him again until he'd taken action on that. And I think that's very important. Okay. So here again, he was a sulfur, very dynamic sort of a guy, a CEO type, owns his own business. And when I first saw him, he was sulfur 6X. Next time, he was sulfur all X, along with lachesis mutus. So he came in, very, very much in charge. And I see that there is some sort of a relationship between lachesis mutus, which comes from the surucucu snake, and sulfur. But basically, he's a sulfur constitutional. We cleared up the lachesis state on the second visit. Other things that we looked into were the lymphatic system. And you can see that the interactive problems there are sulfur, syphilinum once again, which I see in all cancers, and lymphogranuloma had a very high potency signal, and scarinum. There was a lot of scar tissue in this area. And I think that this might be related to group A strep, the chronic expression of group A strep. You see it very useful in patients that have dystocia of labor, a lot of scar tissue formation. Scarinum will balance out with thios and graphites and silicene. Usually find those all in combination. So scarinum has something to do with scar tissue. Now the lymph burdenings, the OR1-1, here again, you can pick up what your miasm is going to be and see where it's expressed elsewhere. In this case, it's expressed in the lymphatic system. But this is a good place to pick it up, and that's where we pick it up first, in the OR1-1, which is a specific point. The lymphogranuloma also was shown at that time. Usually you only see one, but in this case there's two. Later on, carcinosinum, which is another miasm, came up in high potency. Now, we went to the lymph nodes, the CI8F, and we were able to pick up an eccrine cancer. I told him to bring the slide. He had a biopsy. I said, bring it in. We'll see if we can identify it. If we can get a biofeedback signal located in the region of the lymph nodes. So we went to the lymph nodes, and we found generically that the eccrine tumor was there. Sulfur, syphilinum, lymphogranuloma, and scarinum all had an effect on the lymph nodes. This should be SI4A, and you had sulfur, a Faecalis alkegenes, bacteria, and tuberculin rosenbach. I think these are secondary points. I don't know if they have any primary effect on his cancer, but it's like anything else. We're not separate parts. We're totally all one. Now, as time progressed, we went from February, we're now up to December '93, and I see the non-gamma 2, and it was all X, and he had a root canal, all X. The right upper first molar, he had non-gamma 2. The right lower first molar, I was able to identify the nosode for a root canal. The right palatine tonsil now showed porocarcinoma at 4X. And it seems to be now, a lot of times, what I'll see is very high potencies initially, and then the next time around, you get to see the low potency, a more realistic view of the correlation between X's and the size of tumor. And that's and that gradually progressed until we even had a negative right here, and yet he still had a tumor. Now that means that either we're misreading this totally, or there has been a subtle change in the nature of the tumor so that we don't get an exact signal feedback. And that's one of the big dangers. You can't use this as a diagnosis. All you can use it as a signal generator and useful for biogenic information. But the point I want to bring up is that you can lose these signals transiently because maybe the body isn't dealing with it that day when they walk into the office. It may be into some other things. You know, the body is like that. You know, so you may lose that signal for a period of time, but it'll come right back again because the next visit it was right here, okay, 20x, but it was still going up, 4x, 24x, right about here, but then it started to grow, and that's because he still has his silly mercury in there. You know, he still has that toxicity. He hasn't gotten rid of the mercury amalgam. So the case is not moving, and that's instructive. That you have to get going early on this, and get your patient to do those things, and tell them, look, taking the mercury out is either real or not real. You know, it's an empirical science. If you take it out and you get better, I was right. If you take it out and you don't get better, then I was wrong. There's no way you can make any judgment about that unless you take out the mercury. So I mean, it's a simple fact that it's not predictive in that sense. All right, so what are the other areas? Right laryngeal tonsil, that's where we see it. And now for the first time I picked up Agent Orange, and we picked it up again in September. And the DDT was picked up right here. That eventually showed up. And so that's well down the road, but it's now going out, okay? These signals will come and go, and just because they go, don't say you got rid of it. You have to, next visit down, go through the same thing again.
Question.
Sir?
Is that possible because of the pleomorphic state of our microbes and bounces back around and forth?
Whatever the signal is, I don't know. It's just, what you have to do is report this and say, well, look, this is what I've observed, and then you get a series up and say, well, you're going to have a positive rate of confidence that it will show up 90% of the time, or 80% of the time, or 40% of the time, whatever it is. But that requires numbers, and you just have to sit down and crunch a few numbers. Now, my whole life is not cancer. Here's a case of a young lady who has polymyositis and Sjogren's syndrome. She's 44 years old. She had multiple amalgams placed starting at age 17. She had a complete restoration, beautiful work, really wonderful. All gold and caps and crowns and all that. And it was all completed 3.5 years ago, and that's when she started to get sick. So she had ceramic gold crowns, she had root canals and other alloys, and the allopath has treated her with methotrexate and prednisone, trying to kill the messenger, but not going after the cause. A significant point here is that she had a history of Bright's disease, and should you put any amalgam or any heavy metal in a patient that has an autoimmune disease? I say no. These are hyperreactors. So this is one of the cases where you as dentists should look into the background for autoimmunity and say, hey, look, I'm not going to put this in there.
What is Bright's disease?
It's a glomerulonephritis, strep infection. So if you have histories like that, you have to sit down and take time, just take the history. Okay, here's how we approached her. She was pulsatilla, kind of sweet lady, very passive, gentle, trying to please, kind of wept a little bit when she thought about her teeth. A little sad when she first came in. So she was, it simply says that was her state at that time. She turned into a sulfur after she started to get better, and after she came to the realization that she had to do something. So you can see the positive response and the dynamic going on here. The lymphatic system of the jaw, the LY2 point, demonstrated ceramic gold, nickel, chrome, gallium, molybdenum combination, and chlamydia. So you do have a bacterial infection, and menorrhinum, which is gonorrhea, and that will cause hyperreactive reactions. Once again, we can see that the silver amalgam, the non-gamma 2 amalgam, and all of that remained and continued to be a case right up until 9/6. The skin reflected mostly the DDT, but she also was real sick about that time because of a flu shot, and that's identified influenza toxicum. But notice once again the DDT went from 24 to 200, and that's a general rule that that's the direction, if you're going to case manage, that's the direction you want your case to go. You want to get the X's up a little higher. And ceramic gold and non-gamma 2 are found now in the skin as well. So you can see that the ceramic gold just doesn't affect the teeth; it affects a variety of points. DDT.
Interrupt you a second.
Sorry. Yes, sir.
Comments like ceramic gold, there's 100 different
Yeah.
kinds.
Well,
Are
that
you
Doug can
differentiating this at all?
Doug can identify that. Ceramic gold is.
It's a preparation from the Stoughton Company in Germany under the name ceramic gold. You have to check with them on what the exact product was. I don't know exactly.
A lot of
There are lots of different
Yeah.
ones,
A lot of
but of course with homeopathic testing, if something is similar, close enough to a category, you'll get a response with it. It's the closest title that you have.
And I find since Doug expanded his library that I can get closer to it. It's very selective in that sense. And
If you have more options to choose from, the buyer's gonna get the one most,
yeah.
even more close to what
Mhm.
you have. If you give it certain options, it'll pick something that's maybe close but not identical.
Well, this, Sjogren's syndrome is an autoimmune disease, and there's a point right here on the thumb, the inside of the thumb, on the palmar surface called SV91, or it's the autoimmune point, and you can see the influence of the constitutional. So that penetrated into the autoimmune area. Nickel, which is probably the key agent in the nickel, chrome, gallium, molybdenum grouping. And sometimes I'll do that. I want to say, okay, well, what's, of that grouping, which is the most offensive? And nickel came up as probably being the reactant in that combination. I also picked up titanium, and there was an infectious process in June that had gone, and now we still see the non-gamma 2. And this lady has spent $10,000 getting her teeth restored. And for me to go up and say, well, I think you ought to take all that stuff out, she was less than enthusiastic about it, and I've been very patient with her, but at least we're getting her cleaned up, and she will be in better shape to have her last visit with me, she said, well, I really have to have all these taken out. And so I think she'll act on it. All right, here's another really interesting case of breast cancer. That was a gestational breast cancer. It started in pregnancy, and if you're familiar at all with gestational breast cancer, these patients die, and they die quickly. When I first saw her, she was 45 years old. She had a lumpectomy, and when I saw her, she had her child on the breast, and he was breastfeeding, and he's still on the breast. And the lady has had a good response. Now, how did we approach her? Well, this is a slide that shows that I wasn't always doing what I'm doing now. This is a process of evolution as to what I should look for and the way I should test for them. Back in 1982, in August of 1982, when I first saw her, I wasn't testing for the LY1-2, and consequently I don't have that information on her, but later on I do, and she basically is a calcaria. But what I wanted to show here was that once again we have a cephalinum as a precondition for malignancy, and I was able to identify a colloid carcinoma. It was a big bulky type of carcinoma that she had residual. Eventually I got her to do the lumpectomy, and I was able to show that she was really a toxic dump. She had benzene and pixcrutum and 2,4,5-T-ester, which is a kissing cousin of Agent Orange. It's an herbicide. Heptachlor, aldecarb. There's an infection with chlamydia, molluscum contagiosum, herpes simplex, and I was able to identify in the mammary gland, and these are all signals that came up in the mammary gland, of of these different agents. I had one gal who was 36, had 35 different chemicals in various parts of her body. And yet I've had 90-year-olds that come in with practically nothing. So it says that there's a wide biological variability on how we absorb our environment. She was a sulfur to begin with, and then she ended up as a calcarean. She vacillated back between calcarean and sulfur. The basilinum was the big thing that was stuck the most. And as you look at this, what have I done? I've gotten rid of the syphilinum, and syphilinum is always associated with the destructive patterning. You see ulcers of stomachs leading to bleeding, gastric cancer, ulcers of blood vessels leading to hemorrhage of the blood vessel wall. So you have hypertension, heart attack, and stroke. And you see also syphilinums in destructive behavior patternings, psychoses and things like that. So, but basilinum basically refers to the lung, and she had a more benign course, is what I'm saying. So my thesis is that if you can take away the syphilinum, you've changed the patterning of this individual. That even if she does continue to react to these various things, she will not be reacting in a degenerative fashion. In other words, you've changed the essential biology of the individual. So now the path that she's going to go down is not going to be a destructive cancer pattern, because that is a syphilinum. She's going to go down to a more proliferative problem, sensitivity reaction type with basilinum. And basilinum is TB. And you can see where it went from 200 to 200 to 900 to 9 LM. That's 50,000 times 9. And then that particular miasm cleared up early. And I find that miasms do clear up within 2 or 3 visits. The degenerative mammoth scurinum, 4KX, was found in the triple warmer 1D, which is the mammary gland and the mammary gland at the nipple. And I was able to show also that there was a different potency in the, this is the mammary, this is scurus carcinoma, mammoth scurinum, in the breast itself, but in the lymph nodes of the axilla, there was a higher signal. So you can discriminate a little bit about the amount of tumor that's in the axillary nodes versus the amount of tumor that's in the primary site.
Question.
Sir.
Not having studied the IABDM very closely, I see all these detailed anatomical correlations with measurement points. How well established is that? I mean, you're doing triple warmer 1-1, and you say it's the axillary nodes, if I'm not mistaken there. How firm is a correlation like that? I mean, is that real, or is that virtual in some way?
Okay, just a little note on that. As I began working with Voel's work back about, I began 14 years ago, began testing after a couple of years. At first I was a little skeptical, how could these be so detailed? So after testing about a year of work, getting a history, and then seeing if anything would correlate, I decided to take the plunge and do a Voel's method, which says, don't tell me anything, let me tell you your problem.
Yeah.
Which then I had to trust and give the benefit of the doubt, does this stuff really work? And as I began to go through, and I would find the problem, and then I would probe the history. When I had one of these exact areas, I found just uncannily accurate, how accurate Dr. Voel was with his correlation with all these points. As I went through it, I've added about 300 new points on the same way. We measure it and find the point that describes their pathology. Then we get as much as we can from history, from blood tests, from other studies, and MRI scans, where we say, here's a tumor in this part of the brain. This is the point that had the disturbance. Here is a problem in this part of the colon. Here's the X-ray. Here we can see it. Here's here's a point for prolactin, and they have elevated blood prolactin levels, and they have a tumor in the pituitary, and all those things show up that it is amazingly accurate. Part of the way of identifying it is putting in circuit and a dissected organ-specific tissue from animals to see if that resonates with a specific point, which is another part of the discovery process. So those that work with it clearly, have found, probably you've found with your experience a lot of times you'll find something and then it correlates when you had no other way of finding out except point measurement. So
I find it to be very consistent. And I'm presenting this purely because it's that kind of question that has to be answered. Because it is at variance from common experience in EAB. But I mean, we're continuing to make these advances, and I see those correlations. And I also question when I don't see them, okay? Okay, now I have to get going on this. Essentially, what happened is that she still has some problem in the mammary vessels in the axilla. Now, this lady is allowed for no surgery other than for a lumpectomy. And the one signal that I got is Zahnschmelz, whatever that is. It's a tooth defect. Maybe Dr. Seidel can tell her. Okay, Dr. Seidel? What is Zahnschmelz?
Zahnschmelz is the dental exterior part of the tooth.
Oh, the dentin. Dentin, okay. Well, there must be some enamel problem then, okay? Now I did find that affected her axillary gland. And the point I want to bring up about this case is that although she has, I mean, she looks like a horse. She looks very well. I mean, really very well. And yet, you have to follow these patients. I noticed just on Thursday that we got a CEA, and the CEA is still calling up. So, and she still has a soft axillary node there. So you do a physical and you do all this wonderful stuff, but you still have got to be very skeptical about getting rid of cancer or having a cure. You just cannot just dismiss a patient because you don't feel it any longer. You're not assured at all that you have bioenergetically or through this device located all the tumor sites, and you have to use other methods of evaluation. And CEAs are very good, or CA 15-3 or one of the other tumor markers are very good. You should follow those patients and see them back. I see my patients just as regular as clockwork. And I always am a devil's advocate in the sense that I'm saying, well, I didn't do anything yet. It's not completely over. Okay. Only time will tell, and longitudinal studies will tell. And I think claims for this, that, and the other thing will take on a more realistic proportion. I'm running a little late. I just want to go over one other case. This is a gentleman who's 34 years old, had a left orchiectomy in June of 1991 for a testicular cancer. He had embryonal cell carcinoma of the testis, and incidentally, he had a lot of psoriasis as well. He had his left orchiectomy and his first recurrence on 4/9/93. He received chemotherapy initially, and there was a good response. And then he said, "Time out, guys. It's not going away, and more chemo isn't going to help me." He came over to see me. And when I first saw him, he had a 10-centimeter fixed mass in the left parametrium, right down here. And with homeopathics and all of the things that we go through, we had a complete response by 6/3/94. That is 11 months. Now, this is a recurrent, previously treated embryonal cell carcinoma of the testis. His health improved right along with everything else. The cost for that in my office was $3,100.58. That's a lot of testing. Okay. Now, basically, we went through the same routine. He was sulfur turned into a calcarea as he was getting better, and then, interestingly, he always looked a little sad. And after he recovered, he was a nature mirror, and he was verbally abused a lot when he was a kid, and a very poor image of himself. And that came out only after a while. Okay, so the nice part about being in practice is that you follow your patients, and you see them, and you can look into it. Now, this is either real as far as detecting constitutionals or not. I find it to be useful, and I can see constitutional portions when I identify these points. He had a lymphogranuloma, all K, in the OR1-1, but But that disappeared very, very quickly, okay? Chlordane was a big deal in the nose. Where did I say chlordane affects itself? Mostly in the genitourinary area. So chlordane may possibly have been a very real precondition for this, for the growth of this tumor. And I think it's important because if you're going to get involved in a public health project, you can say, look, at 90% of my patients have chlordane. We ought to get some enterprising manufacturer to say, in this country, if you want to clean up the background, get somebody to make homeopathic chlordane and give it out. And maybe with kinesiology test it or some other method. But the point, I'm not into that. I just am into saying, well, look, let's define what the problems are. And I can tell you, chlordane is a big deal. We found that he had an embryonal cell carcinoma of the testis 8X at the lymph node of the testicles. And he also had a serinum all X. I have a feeling that might be related in somehow, but the other cofactors are cytomegalovirus, all X. That showed up in January, that's the next month. So not everything shows up the first time. And I'm very meticulous about this. I mean, I go over patients, and whether my technique is perfect all the time, it is technique dependent a lot. Sometimes I may miss things, but generally speaking, the big guys I hit. Notice what's happened here, though. It went from 8X to 400X to 4KX to 6LM, and then no cancer signal at all. And this is from my embryonal cell carcinoma testis that I have in I have a slide box of some 300 different slides, and you can use the information, the bioenergetic information on those slides to give the signal that you're trying to balance. Okay, so what I'm saying is that you might be able to use this as a screening technique. And if a patient comes into your office and says, I don't feel well, then you can say, well, you do have the signal for embryonal cell, and you're going to have to confirm it under the current medical paradigm. You're going to have to confirm it and make the histological diagnosis of embryonal cell carcinoma. Now, for those patients that don't want to have that, I think there's an advantage because you don't introduce the factor of I've been deeply wounded, of surgeries. Although the patient may not be aware of the surgery, your body says, I have been deeply wounded when you go in and do all these procedures. And it's an arnica state, and you have to deal with the surgery. So it is stressful in that sense. Okay. Now, I found that by June of this year and September, that we had this non-gamma tube in the head focus. It was located in the lower second bicuspid, and that he had some chest pain, and that it balanced the heart point, the point right here. Cellular metabolism also was influenced by the non-gamma tube. So here we see where dental problems, you can help this man out a great deal if you're skilled and can correct the underlying issue. Here again, we found other things, the DDT, and you can see the same general progression. One of the things that I find frequently is that the skin lesions are not infrequently associated with pork, and so are arthralgias. The arthralgias are certainly Pyrogenium suis, most of the early cases, and then subsequently the nightshade groups, the potatoes, tomatoes, eggplants, bell peppers, and tomatoes. So you can pick up, and I have recently a cancer of the pancreas, a patient who has low back pain, and one would think that it's due to the neurovascular invasion of cancer into the plexus behind the pancreas. Couldn't pick it up there. What I did find is that he had an arthralgia in his lumbar spine related to nightshades. But see, if I were just a standard physician looking at this man, I'm saying, well, you have your cancer, it's gone away. I cannot pick up any signs of the cancer. I would say, well, it's simply a progression due to neurovascular invasion. They get pain that radiates right through, and it's a boring pain. So this doesn't bore, it just hurts me when I sit down. So it didn't have the characteristics of neurovascular pain. So you have to have some clinical experience about this, and so I looked for other things. And what did we find? We found that he had, told him to stop eating tomatoes and potatoes and eggplants and bell peppers and things like that. So we'll see what happens. But we also gave him some bromelain and other things to help his to get off the immune complex disease or immune complexes that are on the surface of the cell. So I hope from this little presentation that you got some insight into the complexity of the issue, of your central role in management of these cases. And it is not an incidental thing, it's an essential thing. And I have to admire you, Ben, for being as dogged as you are and for your awareness long before I was of the risk factors of dental materials and the need for a skilled method of removing these. So I wanted to encourage you to keep up your good work, and hopefully we'll be able to get some integration now between the information that's generated here and yes.
Could you give us the definition of miasm?
A good definition of miasm? I thought miasms are basically influences that are bacterial in origin. And in this case, they are the ones I showed you, the Serinum, Tuberculinum, Syphilinum, Menarinum, as the major ones. But they are basically...
So you mean the incidence is like people who are sick previously?
No, it doesn't mean that at all. I don't know where it comes from. I don't know where they come from. I have a big theory about this, but I don't want to discuss it publicly because it's controversial, but I think a lot of this is actually generated from DNA. These signals, in other words, you don't catch syncephalasm racemosum. I mean, it's got to be, after all, the DNA is how many billion bases long, and when you fold it over, it's probably 100 billion different bases or combinations. So a lot of this information, I think, is integrated within that big information base called DNA, and the events going on have in the cytoplasm. That's called endocytobiosis.
One last part of the question. Final question.
Sold for.
Sold. Very good. Thank you for a most informative look at what you're doing. It's important that the dentist and the physician work together. I certainly hope you have someone capable of doing an adequate job. One of the things we want to do here with the Nova Vita Institute is to do education where we can safely talk about things that we find, and hopefully we can implement them here and document them so that we can eventually have this done, have the orthodox people look at us and maybe go mainstream, because I think we have a lot of answers. And this is the work of a lot of people that have gone on in the last 30, 40 years to bring all of this about. But they're not listening. They're over-consumed by their economics of the situation, and everything's in a flux. So maybe we have a safe haven here in Puerto Vallarta for at least the time until the Civil War comes. But that adds spice to life, right? Okay. And more mundane things, we're going to have a nice buffet lunch out at the thing, out on the cabana or wherever it is out there. And then at 5:30 in this next room here, we're having a no-host little get-together for an hour and a half. And we invite everybody to come there and mingle and introduce yourself. And another thing I want to say while I'm thinking about it right now is it's important for dentists to work with physicians and physicians to work with dentists intimately, refer patients back and forth, and then you can start to see what works and what doesn't work, at least out of the clinical end of things. And we look for information like you're deriving, compiling, to direct us. We have a need for translating books, not only from Spanish to English, English to Spanish, Spanish to German, German to English, and English to German. So maybe eventually we'll get into that too. Does anybody want to say anything, and then we'll just break up for lunch? Oh, yes, we have Jess Clifford's video tonight at, about 8 o'clock, or 8:30, 8 o'clock. 8:30, okay, so we'll do that. Did I forget anything?
It's now 12:45, what time do you want